Hello and welcome to our final lecture. This is Pain Management 107, and we're going to be continuing with different therapeutic interventions for the treatment of pain. So let's talk about proper drug selection, and let's start by looking at muscle relaxants. So these drugs, basically what they do is they reduce musculoskeletal pains and also spasms. Their exact mechanism of action when it comes to reducing musculoskeletal spasms is not entirely understood, but they are generally thought to work by reducing the level of excitation and enhancing the level of inhibition when it comes to pain signaling. And also, they mimic or enhance the actions of inhibitory neurotransmitters such as GABA. And GABA is a chief inhibitory neurotransmitter in the mammalian nervous system. So some of the side effects with these drugs is that they can cause sedation, drowsiness. They have some potential for abuse, and then rare but serious effects of heart failure and paralysis. And let's look at some of the muscle relaxants. So some of the muscle relaxants that you're traditionally familiar with is something like baclofen. But paradoxically, drugs like benzodiazepines, and these are traditionally used for treatment of anxiety or even sometimes occasionally acute psychosis, they're also actually very effective muscle relaxants, and they can be used in patients with muscle spasms of any origin. As you probably are aware, benzodiazepines are very sedating drugs. So doses that are needed to treat muscle spasms can also cause sedation. Baclofen is just as effective as benzodiazepine, but it has a lot less sedation, and some of the higher analgesic properties of it may inhibit the release of substance P in a spinal cord. So let's look at some of the other muscle relaxants. As you're probably really well familiar, cyclobenzaprine, and the brand name for cyclobenzaprine is Flexeril. So majority of physicians know cyclobenzaprine as Flexeril. This one is a really great muscle relaxant. The problem with this muscle relaxant when it's used orally that it's also highly sedating. So it will make you very drowsy. It has high incidence of lethargy and confusion. Also, it has anticholinergic properties. Remember we talked about that. Dry as a bone, red as a beet, mad as a hatter. So all of those anticholinergic properties are also present when you're taking this drug orally. Guaifenesin is a much lesser known muscle relaxant. There's not a lot of information on it, and it's sort of used off-label as a muscle relaxant. But it's basically a prodrug that's converted or metabolized in the body to another muscle relaxant known as Roboxin or methylcarbamol, and this one is a very effective muscle relaxant. And then tizanidine is a clonidine analog. You probably know clonidine is a medication that was originally developed to treat high blood pressure, but then later was found to have analgesic properties and became used for pain. Well, its mechanism of action is it's an agonist at alpha-2 receptors. So it basically reduces spasticity by reducing central nervous system activity. Because it's a medicine that can lower your blood pressure, there's a potential for low blood pressure, hypotension, but compared with clonidine, it's a significantly lesser risk. So here, if you look at all these different muscle relaxants, so you should know the brand name for Flexeril, cyclobenzaprine, and you also should know that we use baclofen quite often. If you were a physician who was prescribing this different muscle relaxant, how would you gauge which one to prescribe? You basically would need to know a patient's medical history, age, social factors. For example, like I mentioned, cyclobenzaprine is very sedating. So let's say you have a patient who is a taxi driver who's driving all day, and that's how he works for a living. So is it a good idea to prescribe a drug that's highly sedating to somebody who's behind the wheel all day? Roboxin is a lot less sedating, but you would look at their other medications, patient's medical history, and that's how you would make a proper choice. And just to reiterate, baclofen and cyclobenzaprine are the two muscle relaxants that we use in a topical form. Anticonvulsants. This is a different class of medications that are used for pain management. What you need to know about muscle anticonvulsants is that they do exactly what they sound like. So they are originally drugs that are used to treat seizures or for seizure prophylaxis or to treat status epilepticus. They're also highly effective for treating pain, specifically neuropathic pain. And when we talked about neuropathic pain, we talked about the pathophysiology of pain. And when we talked about chronic pain, we mentioned that chronic pain can sometimes be a result of acute pain. And also remember that our nervous system, it's plastic. That's why it's called neuronal plasticity. It's adaptive, and sometimes it could be maladaptive. So what happens in neuropathic pain, you can have changes in the sodium and calcium channel subunit expression, and the chronic nerve injury will actually lead to spontaneous redistribution of this channel. So what that means is that normally your nerve cells, neurons, they will fire, they will generate an electrical signal only in response to a stimulus. Remember, a mechanical or a thermal stimulus, like an injury when you burn your hand. But here, with chronic nerve injury, you actually begin to see nerves that become maladaptive, and they become spontaneously firing. So they keep generating all this electrical signals when there's no injury. So what anticonvulsants actually do is they block sodium channels. Remember, sodium is involved in generation of electrical potential. So you can't generate a signal that will be propagated from the peripheral nervous system to the brain, because anticonvulsant will be blocking it. And also you need to be aware that different studies, clinical randomized controlled trials, actually demonstrate the efficacy of anticonvulsants in a treatment of myriad of different neuropathic conditions such as trigeminal neuralgia, painful postherpetic neuralgia, diabetic neuropathy, HIV polyneuropathy, and even spinal cord injury. So let's look at some of the drugs that are anticonvulsants that we commonly use. So gabapentin, and the brand name for gabapentin is Neurontin. Most physicians know gabapentin as Neurontin. So this one is a structural analog to gamma aminobutyric acid, GABA. And remember, we said earlier that GABA is a chief inhibitory neurotransmitter in our nervous system. So what gabapentin actually does, it will bind to voltage-dependent calcium channels and will reduce calcium influx into the cells. So it will likely influence neuronal function and activity at many different sites. There was a study done by this researcher and basically considered gabapentin and Lyrica as a first-line drug in the treatment of neuropathies. So Lyrica is an analog of gabapentin. It's a newer drug that came on the market. The generic name for Lyrica is pregabalin, and the two of these drug molecules are very closely related. They work similarly. There are very few side effects associated with gabapentin, and it's generally very effective. The median daily doses are very high. Patients need to be taking high doses, even up to 3,600 milligrams in order for it to be effective. But topical doses are a lot lower. And side effects are hyponatremia. You should be familiar with what hyponatremia is. Also dizziness, fatigue, somnolence, weight gain, and some of the cognitive side effects. Ketamine is a class of medications. It's a dissociative anesthetic, but in pain management, it basically works as a non-competitive NMDA receptor antagonist. It also has some opioid activity, and we're going to use it in an analgesic to relieve pain. It works in pain management through a variety of several different mechanisms, but some of the more common mechanisms are calcium channel blockage. It has some effects on glutamate receptors and also some action on the opioid receptors. It's basically thought to work on the peripheral opioid receptors, sodium and potassium channels. There's a lot of data that's now coming out that supports ketamine clinically for using it for pain. For example, there's a study And in this study, we had 28 patients that had moderate or severe refractory pain from peripheral neuropathies. And these patients received a treatment with a topical cream that contained 2% ketamine and 1%, 2% amitriptyline and 1% ketamine. And what the researchers actually found is that there was no significant absorption of these drugs, but 89% of subjects rated their satisfaction level as 3 out of 5 or greater, and 2 of the subjects were completely pain-free. Another study found that when ketamine was applied, even in concentration as high as 10%, it wasn't detectable in systemic circulation, and it had no effect on separate painful limbs when it was applied to healthy limbs, meaning there was no distribution of drug in the systemic circulation, otherwise it would have been acting on the painful limbs. So the data supported basically local effects of ketamine, its effect on NMDA receptors, sodium and calcium channels. Now we're going to talk about the drug known as clonidine. This drug was initially developed for the treatment of hypertension or high blood pressure. It's an alpha-2 adrenergic receptor agonist, but later was found to have great analgesic properties, so it was used for the treatment of pain. And it's actually already available in this amazing patch. The brand name is Catapress, and it's basically a clonidine patch, and it's a transdermal therapeutic system for the treatment of pain. Intrathecal clonidine, basically applied directly administered into the brain, was shown to produce analgesia for both acute and chronic pain. And why does this drug work? Because alpha-2 receptors, these are G protein coupled receptors for those of you who have a background in biochemistry, and they're present on the nociceptors in the epidermis, which is our layer of skin, and basically they are cutaneous nociceptors. So typically, the way that this drug works is that it basically affects by blocking the release of norepinephrine by activating these receptors. And also it exerts some of the effects in the descending pain pathway, which is responsible for the perception of pain. Capsaicin is another pharmacological ingredient that's used to treat pain. So capsaicin is a common ingredient in chili peppers, and basically this is a drug that's responsible for that sensation of heat. It's a substance P depleting agent, and what it will do will cause an initial burning sensation that will dissipate after 5 to 7 doses, but the patient must be compliant. And it's often used for the treatment of arthritis. You can see here's a Walgreens version, and specifically says arthritis, pain relief, musculoskeletal, and even neuropathic pain. So these are the typical doses. These are the doses that we use, 0.025 up to 0.075. This drug has minimal systemic absorption, and the side effects are mainly local soreness, sensitivity, and erythema at this site. So again, let's go through the mechanism of action. So there's kind of like 2 things that are going on that you should be aware. Yes, it is basically a substance P depleting agent, which is going to, so what it's going to do is going to cause the release of substance P from the receptors, depleting the amount that's available for signaling, and then block the reuptake of substance P. And substance P is a very important chemical messenger that's involved in the pain signaling pathway. But on the other hand, what it's also going to do, it's going to bind to the nociceptors in the skin, and basically it will overwhelm the cellular machinery, causing reversible degeneration of the nerve terminals and causing this effect that's called long-lasting defunctionalization. So basically nerve terminals become non-responsive to pain. So this concludes our last lecture. Thank you so much for your time. And here's some reference for you to reference and see where I obtain the images from.